Right, welcome everyone to the board, part one. So we've got a couple of new faces for send item. What I might do actually is if when we get to the send item, I'll let you guys introduce yourselves then. Is that okay? Does that work? Perfect. So apologies for absence. We had apologies from Martin Hanlon, Paul, Laura, and
Patrick Higgs.
Oh, is Patrick not joining us for part one?
No.
No, okay. Patrick, I haven't missed anyone, have I? No. They wouldn't say because they wouldn't be here, would they? Right. Any new declarations of? Oh, sorry. I should say Vicky's Victorious Hotel is standing in place of Paul. Any declarations of interest, new or related to anything on the agenda? No. Okay. Let's move on to the minutes. If could I ask if there's any questions or comments about the minutes? Move to the end. I've got the time it takes for me to scroll to the end to tell me if you've got any questions. Okay, no questions. Let's move on to the action log then. So first item is complete. HFC report. Are you here, Myrna? Did you get invited? Are you getting admitted, rather?
Right.
I think this is picked up in. I think so the action's picked up in your paper, I believe. So can we have the discussion then, or did you want to give an update now?
Sorry, I'm not really sure what we're talking about. Sorry.
But
I've been 20 minutes trying to get on. Okay, I'm frustrated now.
So at last board, there was an action which was around the benefit, but whether patient representatives would be of benefit on the ICS boards, and Lisa was going to have a discussion with the new appointed lead. So did that happen?
So I introduced certainly. I'm not sure, Myrna, whether I had your email address, but certainly Max and Sophie. But if that hasn't happened, I'll.
Yeah, no, I did. I got that. Yeah, Lisa. Okay. Yeah. Thanks. Yeah.
That's okay. So, Myrna,
and
do you want me?
We have got better public representation on the cardiovascular ICS board now. Okay. And we actually had a patient story which was really good at the last board meeting. So
so can we close that off then?
Thank you.
Perfect. And the next item, I didn't know whether
excuse me, I wasn't invited to anything, so let's just, I've not heard any more from anything. So
so it's about having a patient representative, man. I don't know that it was about you being invited, but perhaps Lisa, you could email and pick that up later.
Sure, right? I will, certainly.
That was fine.
Okay.
Sorry.
That's okay. And then the next item was 1138. I don't know whether you wanted to give an update, Richard.
In terms of the suicide prevention item,
yes,
we've got it coming as planned to the Alliance board meeting on Tuesday of next week. So Pam D is leading. Has agreed to lead on that. Thanks, Pam. So we'll go through that at the Alliance board. Perfect.
So we can close that one off as well. And so then that leads us on to the Chief Executive update. Ed, thank you.
Thank you, Chair. So colleagues will appreciate we had the anniversary of the pandemic. Reached the anniversary of the pandemic last week, so it's just an opportunity to say thank you to everyone in North East Essex for their efforts during the pandemic, including colleagues around the board table, and obviously also to reflect on the losses that we've had, which have been absolutely tragic and devastating for people during the last year. Probably the two big items on my agenda are vaccination programme and recovery of services, both of which will be discussed on the agenda, Hassan, so I'll leave that till later. The other three things I just wanted to mention is one, the government's white paper on health and social care has been published, and all CCGs will be making arrangements to move into ICS, integrated care system footprints during the autumn, ready for April 2022 when we expect the legislation to come into force. We're not yet clear on what our boundary will be, and we hope to be clear on that in the coming months. And final two things I want to say is just a thank you to everyone who've joined today to present the SEND paper. I think it's an excellent paper, very detailed, very thorough, and represents some excellent progress. There's a lot further still to go, but I think it's one of the best examples or challenges around integrated care that you could imagine. It's a very complex area, and it's really great to see, in particular, the focus on joint commissioning that we're seeing in Essex, and the improvements I think we'll see for the population across the county as a result. So thank you to colleagues for joining for that paper. And then finally, on the ambulance trust, I saw recently that year to date, E-East is delivering the 7-minute standard for North East Essex, which is a big step forward from previous years. I'm really, really pleased to see the improvements in response times, ambulance response times in North East Essex. I just wanted to record a sort of a thank you to them for all of the hard work, and indeed the partners that support them around reducing conveyances and other measures such as handover delays. So a couple of positives to finish on there, and we can get into the agenda. Thanks, Hassan.
Thanks, Ed. Has anybody got questions or comments about what Ed just said? Mark Corey.
Thank you, Hassan. Thank you, Ed. The only point was, and you touched on it briefly, was why we'd seen an uptake from the ambulance service. It's great to see, really good to see, because we want to support them, the East of England ambulance services, to do their job as best as possible. I just wondered how the positives were coming about and what more we could do to support them to continue with that really positive turnaround. Thank you.
So at least a couple of things from my perspective. One is they've significantly increased their workforce establishment, which means that we've got more frontline paramedics in North East Essex and elsewhere to respond, and I think that's the major factor. But secondly, I think their operational grip and focus on performance has really improved, and I think delivering standards breeds confidence, so it feels like a more confident organisation too. So those would be some of the factors that I would pick out, but other colleagues who work at East may have their perspective too. Thank you, Ed.
Any other questions? Okay, in which case let's move on. So the first item is the send item. I must confess, I'm really sorry, I forgot who the additional people. So I think we've got Sarah, Leanne, and Katrina. Is that right? That's three of you.
We've also got Catherine Searle for this board.
Catherine, okay. Yeah. So
So
what I might do is if it's okay, because I think we're going to have a little bit of an update about the work you've done as well. So if you could perhaps, if I could get you to introduce yourselves in turn, then rather than go around and introduce everyone, if anyone's got questions, comments, and when they ask a question, they can introduce themselves. Would that work better? It's a little less clunky. Yep. Perfect. So Sarah, can I start with you?
Yeah, hello, good afternoon. So my name's Sarah Garner. I'm the Programme Director for the Joint Commissioning SEND as part of my job. The other part of my job, as you'll probably see me pop up in other meetings, is the Associate Director for the UMES Collaborative.
Welcome, Sarah. Leanne?
Hi, everybody. So my name's Leanne Nunn. I'm the Associate Director of Nursing for Suffolk and North East Essex CCG and take a lead on children, mental health, LD and autism and SEND.
It's nice to put faces to some of these names. Katrina.
Hello there. I'm the Vice Chair at Essex Family Forum.
Thank you. And Catherine, I think.
Hello, my name's Catherine Searle. I'm the Designated Clinical Officer for SEND in North East Essex and Suffolk CCGs.
Perfect. So which of you is going to lead on this item then?
So we'll split it into parts if that's okay. So what we'll do is if I share my screen for the slides, Leanne will start first, Catherine will cover the EHCP element, I'll do the joint commissioning, and then of course the Katrina will do the very valued input from the Essex Family Forum. So we'll dedicate the last word to our colleagues at the Essex Family Forum. Okay. So let me
do you want to keep questions till the end?
Yeah, would that be okay to
Just
do
easier
that?
in terms of managing time, if that's okay.
Yes, sure.
Perfect.
Right, let me just share my screen. There you go. Can you see that okay?
Yes, if you go full screen, Sarah, with slideshow, that might be easier.
1 sec. Sorry, 1 second.
If you hit the
Right, can you see that okay? Has that come up in full now? Yep. Okay, right. If I hand over to Leanne, first of all, and if you just tell me when you want me the next slide, Leanne.
Excellent. So mine's still showing the first sort of introductory page.
I'm not sure if I'm on a delay, but I'm not in presentation mode.
Oh, right. So. Okay, we're not in presentation mode, Sarah. Mine.
Right, sorry, 1 second. Right, is that... It's not going to let me do it, I'm afraid. No. Okay. Keeps coming up install graphics card. Sorry, apologies. Let me see if I can make that. It's just slightly bigger.
Yeah, if you could just zoom it a bit, that would be great. That's perfect, Sarah. Thank you.
Excellent.
Okay, so we just want to start off with a bit of background and context. So, as you know, this is a programme of work that sits across health, education and care. So, like Ed has already referred to, it's a piece of work that, you know, we all have to work together as a system to achieve the best outcomes. So, in September 2019, we had the Ofsted and CQC inspection of the local area in Essex, and that was obviously to look at effectiveness and how we implement the disability and special needs reforms as set out in the Children's Act. So obviously as part of that inspection, they want to come in and look at the local system and see how we work, but they really want to hear from our families and young people to hear what does it feel like to be on the end of our services. And they visit a range of providers and look at how it's all being implemented. So as a result of the findings, it was determined that a written statement of action was required. There were some significant areas of weakness, and there was some practice that was determined that the local authority and the clinical commissioning group were responsible for submitting the written statement to the Ofsted. So they essentially tell us the areas of concern, and we have to respond and say what we're doing about that and what our plan is to address those areas of weakness. So the weaknesses highlighted within the report. So as has already been mentioned, it was about the joint commissioning arrangements, and it was about thinking how we have a more consistent offer for our families and young people across the Essex footprint. It was about how we work together, and it was about how we make decisions together to ensure, again, that consistency and that joint working is there in place, because we know that will produce better outcomes. Again, it was about variation between CCGs. It was around long waiting times, and I think one of the biggest challenges within health has been about how do we have that oversight over such an enormous geographical area, and about sort of supporting each other to drive forward the areas that perhaps aren't, have got longer waiting lists, and also just looking at how we work better together. And then there was the potential over-identification of children and young people with moderate learning difficulties. So those were kind of the key areas that were identified as part of the written statement of action. But I suppose the one thing to stress is the written statement of action is really, really important, and it's important that we do address those areas of weakness, but it's about looking at the whole system and the outcomes across the whole board, across the whole programme of work. And we've tried really hard not to lose sight of that, although we've got some specific areas to target. So of those key findings, the weaknesses identified during the inspection, we'll kind of look to address this within the written. So the written statement of action is essentially what are we going to do about what's been identified. So the reasons for and the accuracy of high proportion of children identified with moderate learning disabilities are still yet to be resolved. So the potential over-identification could mask underlying difficulties in communication and language, social, emotional and mental health development. The joint commission and arrangements between the local authority and CCGs do not work well enough. So these statements that I'm reading are statements that were identified as part of that written statement. So again, too much variation, joint commission is not sufficiently informed, and looking at the gaps in services in health and education across that age range. And then EHC plans do not include the information needed to secure high quality outcomes for children and young people. So EHC plans do not consistently secure the right professional advice. So again, we are all responsible to ensure that when the needs are identified, that the services respond in the appropriate way and within a timely way. So again, we'll come on to a bit more detail around that. And if the strategic oversight is not effective in making sure the EHC plans are fit for purpose. So again, there's been a lot of work around how do we quality assure, the EHC plans, because again, timeliness is an issue, but it's also about quality, because, we can issue lots and lots of plans for families, but if they don't contain the right information and what is needed, then it kind of sort of defeats the point, really. So the statement of action it's about commitment from senior leaders. It's about identifying areas of weakness. It's about identifying strengths. It's about having a shared vision for our children and young people we send. It's principles of working together. It's a governance structure, the outcomes we want to achieve, and our action plan for improvement. So these are all areas that we know that we've got to improve on, and there is an awful amount of work going on to look at each of these in turn. So if we can go on. So the governance structure. So the action plan within the statement of action, the written statement of action, was developed by a group of people, senior officers from across the organisations, and that was sort of ratified and overseen by the SEND Improvement Board. It sets out how our improvements are achieved. So it's about how do we have the oversight of all of the work that we've got to achieve, and how do we work together in the most effective way to oversee that improvement journey. So a review of our SEND governance and partnership structures has been undertaken, and this has been an absolute critical piece of work, because there was structure in place already, but we needed to sharpen up that structure, because that enabled us to ensure that we were able to drive forward the improvement at a pace that was needed to ensure that outcomes were improving. So there's been an awful amount of work looking at all of the governance structures in place, where they need improving, looking at other areas within the country about how their governance structures work, looking at the local level of governance up and, sort of moving up into the more strategic elements of governance. So there's been a lot of work go on in this space, and it's about strengthening those governance arrangements. So we're looking at the SEND Improvement Board and the SEND Strategic Governance Group. That is planning to be merged, so that we've got a SEND sort of partnership board that brings everybody together to have that full kind of strategic oversight of the programme. Because as we've already mentioned, it is a very large programme that involves many different elements trying to pull that together. So the work streams which report directly to the improvement board. So if I just try and explain, so you've got obviously your local work streams, your quadrant meetings, that then will look to feed into that more strategic governance group. So again, that's how we keep oversight of the consistency of approach. We've done some work around terms of reference and agendas, whilst acknowledging we need a consistent approach, knowing that there's some local variations that we also need to include in there. So there's been a lot of work trying to pull all of that together, pulling action plans together and looking at everything that needs to be achieved. So the other bit that I just wanted to update you on was the designate clinical officer team. So something that we've really, really valued and invested in from a North East Essex CCG perspective is our DCO function. We all, we have to have either a DCO or a DMO function in place. But what we have recognised is Catherine came into post May last year, and we've expanded that team to include some deputy DCO roles that have come from different clinical disciplines. And that has enabled us to work far more proactively with our partners to look at, so when I mentioned EHC processes earlier, we've been able to go in and work alongside our partners, which is something that we've never really done before. And I think it's been about forming those relationships and understanding what the health element is within our EHCP plans and trying to understand how we can improve and what we need to do differently. We've established a network within North East Essex, so we've got a health subgroup, so that brings all our DCO and health representatives together to look again at how we approach the health element of the SEND system. We've been active within the Essex system in response to COVID, so again there's been a lot of joint system working to look at any issues that have arisen during COVID and how we can respond together as a system. So the scoping of needs and action planning, engagement in relation to statutory roles. We've had participation in Essex-wide EHCP process quality improvement work. That's led to a couple of pilots in the quadrant. So again, I talk about the quadrants, which we've got 4 quadrant areas and North East Essex is one of those. Again, just details there, but we've been involved in the EHCP needs assessment decisions, which again, we hadn't been in the past. We've been providing health link and information for annual reviews. Again, this is something that wasn't in place. And as North East Essex are the health lead for SEND on behalf of the other CCGs, as I've already mentioned, the health subgroup, which ensures that CCGs across Essex are kind of working together. And then we're also leading on the development of Health SEND performance dashboard so that we can see at a glance what our health performance looks like across the Essex footprint, because actually it's really important that we have that overview of all the areas so that we know how health are performing. So, Catherine, are you okay to come in at this point?
Sorry, I couldn't get off mute there. Yes.
Yeah, lovely. I'm going to hand over to Catherine Searle now, as I've already mentioned, is our DCO. Thank you.
Hello.
Thank you.
So I'll just tell you a little bit about the moderate learning disability work stream. So this is something that's primarily being led in North Essex by Ros Somerville, who is the quadrant manager in North East Essex and SEND services, and she's an educational psychologist. There's been a piece of work to look in closer detail at the written statement of actions findings, where in Essex we were reported to be over-reporting the numbers of children who have moderate learning disability in schools. So the plan of work in phase 1 was about identifying schools where there's the likelihood of over-identification of MLD higher than 22.4%. And the reason it's higher than 22.4% is because the national data set last year was 21%. So where we have figures higher than what are the national data set, we've been drilling down into that information. But then also the under-identification of speech and language and communication needs. Also, we were looking at the likelihood of over-identifications of MLD and under-identification of social, emotional and mental health difficulties, primarily because the thinking is that there's over-identification there, but actually what may look like MLD may actually be something else, and we might be missing a young person's other needs in terms of special educational needs. So that has actually happened, and we've had some movement. We heard at programme board last week. So our figures for primary schools moved away from being 34% this year to 21%, which is in line with the national data set. And for secondary schools, around 36% down to 26% this year. We don't know what the national data set is for this year, we just know last year's, but that feels like some progress has been made, and that was just shared last week at programme board. So the work ongoing around that now is to develop targeted guidance and training and support for these schools to improve identification, and also to deliver guidance about the recording of children and young people's needs on the census. The census, the annual school census, is the source of the information about where over-identification was taking place. That's where we get the data from. And what's also going to happen is that there's going to be more work in terms of training and quadrant discussions and data analysis, looking at strategic planning for outcomes and thinking about training needs and the workforce development needed going forwards to ensure that in-school identification is accurate and appropriate methods of doing so are completed. So in phase 2, those processes and systems where data is deviating from what's expected are now getting into place. There's also going to be a deep dive into where we have over-identification, and those figures have changed on particular targeted schools in order to understand that actually once a young person's needs are identified, does that translate into actual special educational needs support in the school setting? And also going to review complaints and appeals and refused requests for plans from parents in order again to understand if there's a shift in what is being identified and then what is being put in place in special educational needs. And again, continuing in phase 2, there will continue to be training delivered to schools and settings around that accurate assessment processes. So the success criteria for this work stream for children and families, so we are looking at young people and their families and children being involved in those early discussions and decision making about their individual needs. Children and young people knowing their outcomes and targets and the help that's in place to support them achieve their outcomes. And as always with SEND, that golden thread of a tell us once approach for families and the needs of children and young people are accurately being identified at the earliest opportunity. And ultimately that should lead to timely and appropriate support where actually there's sustained impact on a young person's individual outcomes as they progress through education. From a professional's view, oh, sorry, Sarah, would you mind just going back a sec? Thank you. There's some data that will tell us where we're being successful around continuing with this assessment being accurate. So information sharing processes between partner agencies such as our Section 23 notifications and pregnancy notifications. So tracking and that being consistent and timely. Ensuring that there's increased consistency in delivery of 2.5-year-old checks, which improves the identification of children's needs, so with our health visiting services. Also ensuring that the number of 14 to 25-year-olds with a learning disability are receiving their annual GP health check and also being registered with their GP surgery as well for that check. And partners having confidence about identification of need, which is in line with national expectations. And our school and setting staff feeling confident and supported, but also competent to be able to identify young people's needs. We would also be looking to see whether there might be a reduction in appeals in relation to schools for children with moderate learning disability, but also as well records of children's needs will be accurate. So that means that we can kind of track and plan for the future around what's needed for our special educational needs services. Thank you. There's lots of information on these slides, so I will let you read some of it as I talk. And this is a really big area of work, moving on to education, health and care plans. And also, one thing to mention is that as we have 4 quadrants, the thing that makes this such a complex piece of work to understand and keep up with is that we have 4 quadrants and 5 CCGs. So there's lots of people involved in this work. And Katrina, I would be very appreciative if you wanted to add anything from a Essex Family Forum point of view on this, as I know that you've been extremely involved as well. So with our EHCP plan work streams, we actually have 6 work streams within this channel of work, which lead on different areas. One is around EHC decision-making processes, another one around annual reviews, EHCP quality, and then EHCP needs assessment, ordinarily available, which is our special educational needs support, and then also agreeing access and support for special educational needs. There are some elements of all of those work streams that sit within these key activities and progress here, and there are different leads for each work stream. So basically the phase 1 around EHCP improvement is around ensuring that we've got that effective leadership and governance in place, which Leanne's already talked about. Undertaking a root and branch view of planning processes, looking at a thorough end-to-end review of our EHCP processes, and thinking about the feasibility and impact on capacity of separating financial support from EHCPs. So that relates to high needs funding being available to families and young people where they have special educational needs support but do not have an EHCP in place.
Catherine, can I just give you guys a sort of a 5-minute?
Of course,
warning?
Yeah, absolutely.
Right.
Shall I skip Catherine into the joint commissioning bit, so then Katrina's got her bit, if that would be all right? Sorry to
Please do.
be
There's lots
rude
of
and
detail there. No, not at all. That's
interject
fine.
across my colleagues there. So what we will do though is we'll circulate these slides if you don't already have them. So for the joint commissioning element, there's 5 areas that we had actions for from the written statement of action, which is therapies, neurodevelopment, equipment, the local offer, and the SEND information, advice and support service, usually known as SENDIAS, just for the acronym there in case anybody's not familiar with it. So we've really made some good pace with the joint commissioning work overall, and so the overall objectives were to establish obviously the joint commissioning group, because that's always useful to have a group in which we can all come together, and to have a joint commissioning strategy, get the work groups up and running, and get the actions delivered that we need to as we are moving along at pace. So the success criteria was to map all the functions, identify the investments, all the scoping, the data intelligence, all of that work in our initial phase 1 across each of the subgroups. So as you can imagine, it's quite a considerable amount of work with data held in various, ports and people and posts and all sorts. So we've made some good progress on that. The overall objectives were to support integrated approaches to the service provision across the CCGs and across Essex County Council as well, to work collectively to commissioning this for our children in Essex and ensure that there is equality of access, because presently each of the CCGs has slightly different pathways for some of the areas, so it really was trying to bring it together. I can't say we've managed to bring it all together yet, but we're certainly aware of who's got what pathway and where our limitations and gaps are as well. So for the neurodevelopment work, you'll probably be aware that North East has recently had a new business case and that has been approved. So that will enable North East Essex to develop a neurodevelopment pathway for ASD, autistic spectrum disorder, and ADHD, attention deficit hyperactivity disorder as well, and that is set to start on the 1st of April. So we're delighted to have that underway. West Essex has also revised their JADES pathway, and Mid and South are just in a series of stop, start and reset at the moment with some of their pathways. So we've got a set of principles that's been established for neurodevelopment that's been agreed under a memorandum of understanding across all of the partners, which has been really useful. And these are some of the outcomes for phase 1 that actually Siobhan, I can't take any credit, Siobhan has managed to commandeer this work stream, which has been amazing. And the phase 2 is to develop those place-based initiatives and the Essex-wide initiatives and to bring them together in an agreed format. So our phase 2, we said, is from the 1st of April to the 31st of March 2022. So that gives us a good year's work. As phase 1 has been slightly shortened due to COVID, so that's only just started in September up until the 31st of March. So we've had quite a reduced time frame in which to get all of these in action. So for the equipment group, this is a bit of a slower work stream, I have to say. It's got one outcome, but that one outcome has got multiple facets underneath it. So so we're making good progress on that. And as well for the equipment store with ACE that currently got North East, they've been really good. They've enabled us to do audits and really supported us on developing what are the top 10 items, because these were the things that we didn't really have. What are the top 10 items that are on order? Why is there a delay? And some of the things that we've discovered is, say for example, one certain brand of walk-in frame comes from Ireland, and that's been impacted with some of the COVID and the Brexit sort of situations. So that was quite useful to just determine that. So those are some of the things that we've uncovered in the equipment work stream. For the local offer, this is a revised website that will be operational around about June time. That's currently in progress, and we're working towards the development of that. So this will make sure that the local offer is more is easier to access, has got up-to-date information, and is a bit more of a robust website. At the moment, it's a good website, but it can be made better, which we're all working hard on developing. For the therapies, so this is the balance system that you may or may not be aware of. Hopefully you are. And so this is a system that has mapped and has the analysis of the population for the therapies. So we've started off with speech and language in North East as well. We've done occupational therapy and physical therapies as well. And in Mid and South, we've just started off doing speech and language, and we'll pick up with OT and PT when some of their services have resumed. So this is just an analysis of the services, the definition of roles across a wider system, where we can work together, where we can make economies of scale, and how we can refine our pathways. So this is the phase 1 of the development of this. Phase 2 will be a single specification agreed, key performance indicators, and then also as well the balance system at place, because it is at the moment very CCG centric. So those are the up and coming work that we've got in there. For the SEND-IAS, we've recently agreed a medium-term business case, which has allowed for the 2 posts that were due to finish on the 31st of March to be continued. So this has enabled some, a bit of a balance in the SEND-IAS team, because their workload is quite intense, and we'll be working with them to develop a longer-term business plan that will come to the board round about September time, and this will be a wider, more constructed view of all the information, advice and guidance that's available, and increase some of the posts that we have there, because they do receive quite a lot of requests for information.
And are we having Katrina coming in as well?
I was going to say, I'm just going to hand over to Katrina for the Essex Family Forum to round us up.
I take it you need a shortened version now. Okay, so we are the Essex Family Forum. For those that don't know, we're the designated parent carer forum for Essex. We are an independent company, and we're solely made up of parent carers of SEND children 0 to 25. Our key activities, we have some family champion leads that started actually in September, and they're really looking specifically to get to those hard to reach groups, because we are trying to represent all SEND families. So that would include home ed community, the BAME community. It would be more the physical disabilities, because we too tend to get a lot of autism, neuro disabilities. That tends to be the bulk of the parents that we hear from. So we're looking to reach a lot more than that. So we use that feedback that we get from those parents to go to the meetings, and we're at all these meetings that we've already talked about, with the aim of improving those services using that voice. We've done the first annual survey, which is really supposed to be the base survey. So in another year's time, which will be October and November, we'll do a second survey, so we'll be able to see improvements in those areas, hopefully. And that will be part of the written statement of action. So that will be used to see families' experience, and hopefully improvement in families' experience. We've also got a virtual graffiti wall that was set up during lockdown. We used to do graffiti walls in our engagements, like in face-to-face engagements, but obviously we haven't been able to do that. So we've got a virtual graffiti wall, could be updated any time by any SEND parent, and and we collect that on a quarterly basis, and it goes to the SEND Improvement Board, as did the annual survey. Phase 2, we're going to obviously do the second annual survey. We've got some other surveys coming out specifically about the ND pathways, the equipment survey. There's going to be EHCP surveys as people are going through that process. And as we're going to be attending, we attend all the strategic meetings as the voice of parents. And that's really that, unless anyone's got any questions.
So thank you all. Sorry if I rushed you through at the end. But remember, actually, part of this was around trying to get teams to board, and although it's slightly artificial with teams, as it were, I'm hoping that when we start to get a face-to-face board, it can start to be a little bit more personal to invite teams along, and so we're all mixing in, and as I said at the start, putting a face to the name to all the emails and stuff we get. So great to hear. I haven't got a great deal of time for questions, but maybe I'll get to Lisa. I don't know whether you've got a question or a comment, have you?
Both, sorry.
Okay.
I'll be quick though. Thank you guys for a really helpful overview. It just demonstrates the complexity of all the SEND work. Katrina, my question was for you, really. I know that we haven't really seen a huge impact at the moment from all the work that we're doing, and hopefully that will be coming soon. It takes a while for impact to kind of flow through. But I wondered, with regards to the survey, whether there's an ability for us to co-produce with you and make sure some of the questions are asked around health services that we would really like to know the answers to from families in Essex.
Yeah, so most of the survey was focused, I would say it was mostly focused on education, and that was really because that's already was input before we even had Ofsted. Lots of those things were ongoing, so we knew that was one to get in very quickly. I think we can add health things to the next survey, but we've also got, remember, we've got the ongoing surveys going on. So I forgot to mention, actually, we're doing the neurodevelopment family resource packs. So as part of that, I would like to have a link in there to a survey as people have gone through the process. And obviously we've got other, we can work co-productively to get any other surveys that you think would be useful, or if we add it to the annual survey, I think that's something to think about.
Thank you.
Okay, thanks. Ed, I think you're next.
Thanks, Chair. It's a question for you as well, Katrina. Just interested from a sort of family's perspective. What do you think, in a nutshell, what do you think is going well? Which areas are you worried about that aren't going as well? I
think in terms of how we're getting parent voice, we are getting involved in the meeting. So in that sense, we're getting our voice heard. And I think in terms of co-production, I think it's quite inconsistent, I think it's fair to say. And actually, it's probably the best in the North East, I would say, but across the patch, and even in education, I mean, I know the EHCP subgroups were mentioned. There's 6 of them, but there's only one we're actually involved in, called a co-production group. Well, I don't really call that co-production. So I think, we're constantly having to put our foot down a little bit to say, boy, what about us? You've forgotten us. And really, it should be embedded in the process. And it's not always. I think in terms of actually family experience, the annual survey brought about the 2 big things were communication at all levels, between professionals at ground level with parents, how you communicate, when you communicate, all those things. And this the navigation pathway, so not having to consistently tell your story again and again and again, and that comes across quite a lot because it's quite exhausting. That's what we hear a lot. The process is exhausting for parents.
Thank you.
Thank you. Richard.
Just firstly to thank the team for the amazing work that's going on. So I think North East Essex is in a really good position around this. So Lisa and I and Ed are leading this on behalf of Essex with our Essex County Council colleagues. And I think we've made a lot of progress, not just in North East, but across Essex as a result of that working together. A question, as Ed's stolen my one on for Katrina, more to Leanne and team. what else do you think the board could be doing? Is there anything the board, I'm putting you on the spot, anything else that we could be doing as a board to push this agenda forward? That if you had anything, what would you want us to be doing?
So thank you, Richard, as if I had a response readily prepared. So what I would say is the impact that we've been able to make through having that DCO team has been incredible, because that has enabled us to sit alongside with our partners, as I already mentioned. So one of the challenges that we've got at the moment is that approach isn't a consistent approach across Essex in all the other CCGs. So again, that investment into that health resource within the SEND programme of work. So obviously and it's not through people not wanting it to be there, but I think if we could help support our colleagues to kind of think about that resource across, so that we can make an even bigger impact from a health perspective. But like I say, the relationships with our DCO colleagues, I know Catherine is made some amazing relationships across, and that's strengthening the way we work. But I think we could do even more. I also think the point that Katrina has raised, I do think there's some work to do around co-production and the understanding and the approach from co-production point of view. We've been on this, this is a journey, and, Katrina knows we spoke about it at the last quadrant meeting, that, I think we need to fully support our parent care organisations in how we all work together in the system, and how we have them alongside us at every stage on that, on that journey. So, yeah. Is there anything from you, Catherine, and Sarah, from your perspective?
No, I would agree with those 2 points you've made, Leanne.
Yeah, me as well, Leanne. Yeah.
Okay, perfect. Well, I think all that's left is for me to thank you guys. Sorry I had to rush you through at the end again, but it's been lovely to see. I think this is, for the other members of the board, this was attempt number 1 at trying to get members of the team through to present papers. And so hopefully we can start to do this a little bit more with each consecutive board. So with big items or large items or small items, we can start to get extended members of the team through to board to start to present, just really so we know who's working with us, essentially. And so you know who we are to some extent. Right. Thank you all. So I'm going to move on then, if that's okay. So the next one is your paper, Richard, is it the IAPT paper?
Thank you. I think it's also a good opportunity so you don't have to hear from Lisa and I and others all the time. I think that's the real reason. On this paper, it's hopefully a straightforward one. You'll recall that last year we went through a procurement process to recommission our IAPT and wellbeing services, and ePut is due to commence that as the new provider for that service imminently. When we originally put out the tender and went through the contracting with ePut, at that point the national guidance was to commission a service up to 25%. As colleagues are aware, there's been a change or a change in the guidance that now we should be working towards 30% access standard over the next couple of years. So clearly that means there's a gap financially in the contract value in terms of what we had commissioned and what we need to commission. So this short paper just takes you through the agreement that we've reached with ePut as the incoming provider in terms of the amount of funding that we will make available, and therefore ePut able to recruit to hit those trajectories over the next couple of years. Just to assure the board that this has been through both, get my terminology right, the Alliance Committee and also the operational executive, given it's a contracting decision on provider. So hopefully, colleagues, this won't come as a surprise, and you're happy to support. Jane or Vic, I don't know if there's anything you wanted to add from a finance or a contracting perspective.
So thanks, Richard. I think you've sorry, Hassan, just to say, confirm what Richard said there. We've looked through it in detail, and it sort of fits within our overall expectations.
Okay. And can I just ask you, Vicky, as well, in terms of original procurement, this is a safe adjustment to make?
Yes, because it's in line with national targets. So all the contracts we commission, they'll be in line with NHS England guidance, which this relates to.
Okay, thank you. So Max, you've got a question.
Thank you, Chair. Can I ask? So we're talking about increasing the funding for IAPT services, and at the moment we're seeing an under referral to those services from other papers in the meeting today. How do those two things sort of tally? I mean, we need to make sure that we get those referrals through, and that people are actually, I'm sure the need is out there. It's just, we can increase the funding, but actually, how do we actually get people presenting with their problems?
I think there's an opportunity, Max, with the incoming new provider being ePut, to actually have a different plan. And I know they're very conscious of the fact that there's a lot of work to do to increase the referrals through. I think the activities out there, if you look at other parts of Essex and Suffolk and neighbouring counties, they're actually over their limit, as in they're doing better than the 25% access standard. So I'm fairly confident the demand's there. It's how we now have a clear implementation plan with ePut as the new provider, ensuring we're getting that access, that capacity, so the access through. This is a longer term investment over 3-4 years. So, we need to make it, because the training for these individuals takes a significant amount of time, even to get them through Health Education England and in post. But in terms of the actual funding, this is the upper limit. So this is how much we expect to have to spend on the staffing, but there'll be an ongoing dialogue with ePut on the basis of actuals as they recruit in terms of the funding that's passed across. So there will be a mitigation in that sense as well.
Thanks, Richard. Any other questions? I think this is clearly one of the services that suffers from, not that anything else doesn't suffer from COVID, more so in that actually the personal touch for IAPT is actually quite important to individuals. And time will tell. I don't know whether that's one of the reasons why perhaps there are reduced referrals, because actually there's an understanding that you maybe won't get direct access to that face-to-face. Perhaps that's a reason, but time will tell. Max, have you got your hand up again, or is that a legacy hand? Sorry.
No, just actually one other question. Sorry. I don't think I picked up in the paper. Is there are we kind of increasing the scope of treatments in the IAP service, things like desensitization therapy, which I know has got quite a good evidence base behind it. Is that part of this new service? Can I ask? It may have been in the papers. If it is, I apologise.
I don't know that level of detail, Max, but I can find out. The model is the national prescribed IAPT and wellbeing model. The major increase is in long-term condition support. So we've got a rollout programme with the Trust in terms of some of our long-term conditions, cancer, gastro conditions. But in terms of that specific one, I'm happy to pick up with ePut to check.
Yeah, I think it's just it's increasingly recognised. I think it's increasingly recognised that a lot of conditions that people are suffering from is to do with post-traumatic stress, and desensitization therapy is an important element of management of that, which is not readily available, and could be better available, I think.
All right, perfect. Maybe that was picked up in the Alliance Committee, maybe it wasn't. But if you could clarify that, that'd be useful, Richard. Thank you. But in which case, we're asked to approve. Sorry, Max, you got your hand up again. You got a third question.
No, I haven't. I'm sorry. I try to maximise the screen to see the presentation. Now I can't see anything.
Right. Okay. Well, you're out of questions.
I don't know how to
anyway.
minimise it again now.
Who's your
I can't see the. Well, I've got my hand. I'm sort of desperate.
Not to worry. I'll lower your hand. So we'll move on. So is everybody happy?
Sorry.
It's okay. Everybody happy with the recommendation? Perfect. Let's move on. So Jane, let's take us to our planning update.
Thanks, Chair. So a paper in your pack really about trying to get us ready for the new financial year that starts on Thursday. So at the time of writing the paper, we hadn't yet received any of the planning guidance or the allocations for next year. Since we've written the paper, those have been received, but we've only had them for a day or so. And so the recommendations in the paper still stand, but just to sort of update the governing body that we have now received a little bit of information about next year, and we're in the process of looking through that. So just to remind everybody that the year that we're just finishing has been a very unusual one from a financial perspective. The first half of the year was centrally reimbursed in full for all NHS providers and CCGs. And in the second half of the year, we moved to a sort of a halfway house where CCGs received an allocation and were expected to live within that. However, a lot of the usual things, such as setting up contracts and plans with our main NHS providers, was done centrally, so that the amounts for those were prescribed. What we're moving into for next year, for the first half of next year, which is what we've received the planning guidance and the information around, is a continuation of that kind of hybrid model. So CCGs will receive an allocation, but there will still be a degree of central prescription around particularly the amounts that we pay to our main providers. So for North East Essex, for ESNEFT and for EPUT, for our main acute and mental health providers, as well as our smaller NHS providers, those block amounts that we paid last year will roll forward with some adjustment for inflation and efficiencies. So, as I say, we're still working through the details of those. Jenny is slaving over a very hot spreadsheet today, trying to understand the ins and outs of those, how they work for the CCGs, but also for the wider system. And we'll be talking to discussing that across the system at a meeting that will be going on later today. But in terms of the paper, in line with that kind of extension of those sort of centrally prescribed arrangements, I've put in some recommendations to allow the CCG to function, given that the planning guidance and the allocations came out so late. So the first recommendation is around just noting the rolling forward of arrangements and allowing us to use the Finance and Performance Committee to do a lot of the detailed work on those allocations and looking at budgets, because obviously it's a couple of months until we meet as a governing body. We would, as always, plan to bring back the formal plans and budgets to the governing body for final sign-off, but just asking to allow the Finance and Performance Committee to be looking at those in detail in the meantime. Secondly, given that we only actually got the allocations a couple of days ago, permission to just roll forward the existing budgets to give us something to work on from the 1st of April until such time as we've had chance to see how they play out and make any changes for those and get those approved. And finally, we put in place a special committee across the 3 CCGs in Suffolk and North East Essex. The CRAC committee, it's not written properly in the recommendation, apologies, it's the COVID Resource Approval Committee, which we use to look at particular expenditure which has been particularly associated with COVID. More recently, it's moved into expenses associated with the vaccination programme, as well as looking at specific ongoing elements of COVID more widely. So that's the paper, Hassan. I know that Richard is keen later to talk about planning guidance and might want to use this opportunity or under the IPR, but that's my bit for this paper specifically.
Okay, thank you, Jane. Did you want to come in at that point, Richard, or save it?
I'm happy to do it now if time allows, Hassan, which saves the later in case I have to leave just before. So just to follow on, so I think, thanks, Jane, that's a good segue into the fact that the planning guidance from NHSE and I came out last Thursday night. This is the guidance we usually get on Christmas Eve, but we've now had it for our an Easter surprise. That guidance sets out effectively what NHSE and I's expectations are for the next 6 months. So it's a 6-month planning cycle, not the year. The year relates to mental health. In relation to that, effectively, there's 2 key deadlines. The first is that we've got to get our draft plan in by the 6th of May to NHS England. And the second deadline is early June. So effectively, we're working to a deadline of early June to get all of the usual planning stuff done. How that breaks down is, again, as it usually does. So the key returns is there's a finance return that Jane will be leading on with Jen. There's a workforce return that Amanda will be leading on with Giles and team. There's an activity return that Jane and Paul will be leading on with Keith and John. And then there's a narrative plan that I'll be leading on with Narinda. So we have internally a weekly planning group that meets on a Wednesday at 4. So all the various leads across the CCGs will be using that group to coordinate the development of the draft and then the final submission. We're planning on coming to both the, I get again the right words right, Alliance Committee and the Op Exec in May with a more of a detailed update once we've got a strong draft for those sections. In terms of the actual guidance document itself, we've pulled together a brief summary. It's 69 pages, the overall guidance. So I've pulled some slides together. We'll make sure circulated to board members after the meeting, and then you can read them at your leisure. But just to give you a brief oversight of what's within the guidance, the following sections are there. So workforce is the main one at the start. That sets out what the national expectations are about refreshing our local workforce planning, our people plan, particularly after the year we've so far had with COVID and its impact on our workforce. And there's a strong recommendations there ongoing around the mental health of our workforce and what we need to put in place to support them on an ongoing basis. There's then a short section on COVID vaccination, which is probably unsurprising, and that's predominantly around how as a local ICS we're going to continue moving forward in terms of the national deadlines related to vaccination, and also start to think through if there is a further booster needed in the autumn going into winter, how that might work. There's a couple of reflections on COVID long clinics in relation to the ongoing impact of COVID on some of our population and virtual wards that we need to respond to. There's then a big section on elective, and as you can imagine, politically that's a massive issue across the country in terms of the sheer scale of waiting lists for our local community to access outpatients and elective surgery. So Paul will be leading on and already has started the work with our 2 acute trusts and our primary care leads on elective recovery planning. In a similar vein, cancer is also covered, as you'd expect, in terms of looking at how we continue to recover our cancer services, everything from screening through to specialty surgery. We're already a long way forward with that. I think we've got a good base plan that we're working on, again, across the ICS and within our 3 localities. The next one is mental health, LD and autism. There isn't a huge amount of specifics within that section. A lot of it relates, as you'd expect, to the ongoing programme we've been working on anyway for the last few years, linked to the national must-dos. So particularly continuing the focus on crisis around our community mental health model that we heard about at our Alliance Committee for the last 2 months. And importantly, SMI health checks, LD health checks and dementia checks that need to come back. Nearly there. Primary care is the next section. And again, a relatively short section, but I know Pam may want to come in later. There's still quite a bit that is reflected within the region that we need to put into place. There is some extra investment, so don't get too excited. When you break it down, it's not a huge amount for each CCG. Nationally, I think it's about 120 million they're looking to put in for the next 6 months. There's then a short section on community care, so that's particularly related to the 2-hour response standard we have for urgents and the 2-day response time for reablement. The short section on 111, so the prominence of 111 within our local system remains. And then there's a big section on the delivery of the white paper. So the changes that Ed was alluding to in his early remarks around having a system development plan for our ICS later this year. And then finally, a section on health inequalities. So building on the 8 high impact actions been working on over the last year, they've now narrowed that down to 5, which is focused interestingly around data, digital, preventative programs and leadership. So that's just a quick canter through the sections, and the summary slides I'll send out after the meeting will give you more of an understanding. Apologies we didn't send it out in advance. We've literally just had it, as I say, in the last few days at the end of last week.
Okay, no worries. Thanks, Richard. And obviously, because this is part 1, we'll have to make sure it's uploaded to the website so it's available when you do send them. You kind of hijacked that paper, didn't you, in the end?
Just a good team.
So any questions or comments? So okay, perfect. So we've got 3 recommendations. The first two are really around the budget. The last is about extending. Gosh, got to choose my words carefully. Then extending the crack. But if we're all agreeing to that, perfect. So let's move on. It's still you, I think, Jane, isn't it?
It is, yes, thank you, Chair. So the next paper is, again, another technical update. This is to present to the governing body for approval some work that's been done on the scheme of reservation and delegation. It's been probably the easiest way to get into this is to look at the 2.2 in the paper. What's happened is a general review, an update, but the main things that have been done have been to reflect the change in governance arrangements, so put in there the Alliance Committee and the Joint Leadership Team. We've taken into account changes recommended by NHS England as part of their work on constitutions, and we've also generally simplified it so that hopefully people could read across and see more easily where things can be approved. So just asking for governing body to review and to approve, please, Chair.
Thank you, Jane. So can I ask if anyone's got questions, challenge? So this is going to be the same across, have we got to a point where it's the same across all 3 CCGs now, is it?
Yeah, so the format and the general content is the same. There are obviously nuances around alliance committees and names of those kind of things in CCGs, but yeah, no, absolutely, they're very similar.
Perfect. So, has anybody got questions? Okay, in which case we're asked to approve, so we approve it. And then it's, thank you, Jane, sorry. And then it's procurement update, which is not Paul, it's Pam, I believe.
Yeah, thank you, Mr. Chairman. It's the confusion between PGs. There are 2 sets of initials which are now PGs. So
well, Paul's just going to have to change his name, isn't he? Let's put that in the action log.
This is a summary document of the procurement activities. People will be aware, I'm sure the public are aware from previous presentations, that Attain acts as our independent advisory and management of procurement service within North East Essex. And I'll take the papers as read, but they outline the procurements that have been done to date, the pipeline of procurements for the future and any considerations. And also there's a consideration within this paper on the proposed changes around procurement and the feedback, procurement regulations, and the feedback that process that Attain are contributing to on our behalf, as well as the NHS and other customers that they have within the NHS. Obviously, that's in line with the white paper, so there is discussion about how exactly those changes would come about if indeed the feedback is taken on board through the consultation process around procurement change. So I'm happy to take any questions around the content of the paper.
Thank you, Pam. So has anybody got questions, comments? Max.
Yeah, I can see that a couple of, or at least a couple of them, are being incorporated in the NIC service, and I think I would support that approach of trying to simplify the number of contracts that we have, because I think it's quite difficult to manage so many different contracts. So simplifying is a good thing, I think.
I think it's lining up pathways and for patients so that there aren't further steps in their process. That is the guiding principle. So within the NICS contract, obviously there is a number of partners, delivery partners, and there is a greater ability to align the services to where the need is in that process. So it's very conscious. But obviously we need to ensure that there's probity around any of those extended pathways.
Can I come back? Sorry.
Yeah, sure.
Just a slight sort of anxiety about the needs contract, which has been, I think, been a pretty successful contract over the years, and its origins were actually moving diabetes services from the acute provider because it was not providing a good service for our population, and has been successfully commissioned from Suffolk GP Fed for several years now. And just a slight anxiety that our acute provider could end up providing that service again when it clearly didn't provide a good service several years ago.
Do you want to respond, Pam, or Richard?
Yeah, I'm happy to respond on that. So I think you know, we are very clear about the successes of the needs diabetic service in North East Essex. I think principal reason for that is the way that it has embraced the primary care interface and also supported staffing gaps to enable better quality care to be delivered out in primary care. It's a very successful model for that reason. We went from the lowest decile of performance around diabetes outcomes to the highest decile. There would be no rationale for us to change that model of delivery at all, and certainly not even to put it within the basket of NICs. Would there be a need to re-procure or give it to somebody else? There is justification enough with the outcomes that have been provided for us to secure the recommission of that service. So
will it be staying with? Sorry, will it be? Are you saying it will be staying with Suffolk Chief?
Even if so, there's two mechanisms. So we've included it within the NIC's contract notice, so that it can be included within that contracting framework. That doesn't predispose who provides it. That predisposes that the Alliance has a decision around the continuation, evaluation and award of the provision to the right provider. So we have the flexibility within the Alliance model that we've got to ensure that it continues to deliver the same quality with the same provider as it is now.
But presumably
thanks, Max.
Sorry,
I think what we want, because I think what this does do though is it reiterates the point, doesn't it, that we need to make sure there's clinical discussion around the NICS contract over the coming months and over the coming years in terms of how it's shaped, and that's crucial, I think, and we just need to be really certain that that's happening, and there is primary care involvement in that conversation.
Absolutely.
To be able to feed in. Okay, any other questions? No, in which case, thank you for the update, Pam, and I'll move us on. Oh, better check. Sarah, if you're still listening, have we had any questions from members of the public? No. Okay. All right. In which case we will then move on. So we'll move straight on to the HFC report. Myrna, thank you. We'll call you off guard.
Do what I normally do and percentages surveyed, but I just feel. I'm sorry. I know that it's a busy meeting, but I would just like to say something about item 2. I feel very disappointed that we haven't been consulted more about what's happening to the or likely to happen to the health forum. I think we've been a very successful forum, and I've been very proud to serve on it. And we've helped lots of people, when they were at the time that they needed the most help. And I feel what happens, it's not that we're against change or wanting, it's just that we heard all we had was rumours. All we kept hearing was people were asking me what's happening to the health forum. I don't know. And I still don't know. And I know that Ray met with Sophie and but I just feel that
I'm struggling. Sorry, Myrna, I'm really struggling to hear you. Do you think you could turn your camera off, just in case that's slowing your connection down a bit?
Can you hear me now?
Yes.
Can you? Is it better?
Yeah, that's better.
Yeah. And I just feel that, we should have been, there were changes afoot. We should have been notified earlier.
Okay.
And perhaps so that we could answer questions. It's a bit silly when we say, well, we don't know what's happening to us. And I just feel that we should have been consulted. If we'd have been making a mess of the job that we were doing, I could understand it. But I don't believe we were. And lots of people have said outside of the area, when they...
Man, I'm really struggling. Your camera's come back on, and I'm struggling to hear you. I think I get the concern. The concern is about item 2, isn't it? About you not feeling included or being included. So
well, we weren't included.
No, so I'm not sure why that was the case. I don't know whether Mark or Pam, were you involved in some of these conversations? Have you got an opinion, Mark? Just from your perspective, Mark Gorey?
No, not really. I mean,
You're
to
aware.
be honest, a lot of these discussions are happening way above our heads. And at the moment, I've sent a letter, as I say, more as a political representative about how I feel about the changes. And we're getting briefed by you and the leadership of the organisation. And at this discussion earlier is another point where we could have had a further say. I think that it's so top down, Myrna, in terms of where it's coming from. I'm not sure what will be listened to from us, but I'm more than happy to take forward as a patient sort of public involvement officer on this board to take forward any comments you have, but also to put them forward now to put to the leadership. But the leadership are also in a difficult position because it affects their roles. So Hassan, I'm more than happy for you to advise about how we take this forward.
So I have to say, because I mean, obviously I've read your paper, Myrna, and it might be useful. I don't know whether Pam or Ed want to come in before, because I think it's clearly a bit concerning that we're not including the existing health forum in the changes that are about with engagement. I'm not quite sure why that's come about that way. Ed, do you want to?
Yeah, so I'm a little confused by this because I wasn't aware of this change being made, and I'm not quite clear on what the change actually is. So I apologise, Myrna. That's not a good reflection on me, but maybe not the organisation either. So I would suggest we take it away and just clarify exactly the position, and then I'll be very happy to speak to Myrna personally and Mark as well. If that's okay, Chair.
Okay, I think that works. I mean, I'm not sure. I know you said it's top down, Mark. I'm not sure it is being driven top down. So I'm not quite sure why there's a bit of a mismatch. And so I think it might be useful for perhaps Ed to be cited on those changes. And I'm happy to get involved as well, because ever since the CCG has been formed, I think the HFC has been had a very crucial role to play. And however patient participation changes going towards the ICSs, one thing we can't do is look to exclude. It may be that roles change, and as you say, there is guidance on how we include patients, maybe in a better way, but that shouldn't be done without engagement and consultation with the existing structures or individuals we have in place. So I'm happy to get involved. Sorry, Mark, you got your hand up.
Sorry, I'm confused as to what we're talking about then. I thought we're talking about the white paper. What item are we talking about?
So we're talking about item 2. Hang on, Pam. On the HFC report, item 2. This is about the changes to patient participation as part of the Alliance. Pam.
So I was just going to clarify that I think Mark was talking about the white paper engagement and Myrna's talking about the restructure of the patient participation roles that align to alliances. And I think, Myrna, the alignment, and Lisa can talk better about this if necessary, but the alignment is to give more resources over to the alliances to be able to engage at greater levels of participation as opposed to denude them at all. I think it's an oversight that you haven't been involved directly in those conversations, and a wider conversation hasn't happened, but it certainly is not, there's certainly not a missing of the boat. There is more resource, that nothing is proposed to be changed in terms of what we're going to do with the HFC at this point. We need to engage. PPGs are essential as well for the primary care discussion. These are all facets of the engagement around the Alliance. So I think what we'll do is Sophie and the lead, when they're in role for North East Essex, we'll have a conversation with you, and I'll be there as well, and then we can really get the patient engagement piece really sorted for the Alliance. We need to be looking at locality level engagement as well, because obviously place is really important, and we're going to be moving to 6 different localities across and teams to much better reflect how people identify with the place that they live and the resources that they have around them. So we'll be looking for yet another level of patient engagement, and we need to link it all together. So it's crucial that you're involved, Myrna.
Okay, thanks, Pam. Mark, got your hand up. So I apologise if I got you confused as to why I brought you in, Mark. But
yeah, sorry, I just wanted to come back and apologise for that, getting confused. I was looking back up the agenda thinking, was it at point 2 that we discussed the white paper? But it wasn't, sorry. So just to reassure you, Myrna, that I fully support making sure we get it really locality based. So backing up what Pam has just said, that's part of, when I was talking about the higher level stuff, that's part of what I want to ensure, that our CCG footprint is absolutely represented with patient experience, making sure that if we get put into a different ICS footprint with Essex, that our voice is not lost. So I absolutely would want to support that, how we evolve the structure and make sure we get that rooted in the kind of alliance footprint that we've been working on, keeping the patient voice in there. Thank you.
Okay, thank you, Mark. Is that right, Myrna? So I think we've got a way forward, haven't we, in terms of conversation? Yeah. Perfect. Is there anything else you needed to highlight from your report? No, I'm hoping the streaming is going to work today, by the way, but we'll find out, won't we, tomorrow? I've no idea whether it's working or not. Maybe there is somebody out there listening to us. Right. Okay. Well, we were asked to note report. Thank you so much. And then we've got the integrated performance report. Paul, you've joined us.
Just
mute. Oh, just in time. I slowed it down to wait for you.
Perfect. Are you waiting for me? Thank you very much. So I'll take the report. I'll take the report as read. It clearly was discussed at performance committee last week in detail. We essentially assured that we were doing everything that we could in terms of managing and working with our partners in terms of performance. I think one of the key important points is probably around the planning guidance which has just come out. And I think as a segue, and I think Richard might want to say a few words about where we are in terms of our planning moving forward, given the position we're starting from. So Richard, I think you wanted to come in at this point.
We've actually covered that. So Hassan, I don't know if you want me to go through it all again. I'm sure you don't. We managed to segue out of an earlier item in the agenda.
Thanks, Richard. Although I don't really remember you saying anything, but I think we'll move on there. No, we've had that update. Thanks, Paul.
Okay,
thanks,
that's
Richard.
fine.
So you done?
Yeah, I mean, I'm aware Martin's not here today, so as the chair of the committee, so unless Jerry wants to add anything to the conversation, I think we thoroughly went through each of the service providers, understood all of the challenges, and went through all of those. And broadly, what you'll be seeing within the report is a lengthening of RTT, lengthening of some of the diagnostic weights that we have, slightly worsening holding the position around cancer, which is clearly remains a priority. And still really a sort of regional national focus on managing urgent cases as we are at the moment. So P1, P2 priorities, but especially from the 1st of April, a clear mandate to start recovering some of those services. So again, I prefer not to add anything else unless people got any specific questions to ask.
Okay, as you say, I think Martin last minute was unable to attend, so I haven't had opportunity to ask him for any comments beforehand. I don't know whether Jerry or anyone else wanted to comment on the F&P discussion?
No, nothing to add, Hassan.
Okay. Thanks, Jerry. So I'll ask the same question I always ask whenever faced with these, is that I know the situation's not great. It's just really, one question is obviously, are we doing all we can to get to a better place? Do you need anything from us as a board? And the second is just really to get an idea of how we are doing comparatively to other areas. Are we better, same, worse?
It depends which line you look at. I think overall, I think we're doing favourably. It would be my answer. There are, if you compare some of the elective capacity, for example, we might be doing slightly worse, but marginally so than some of our peers. In terms of cancer, as you saw in phase 3, we recovered very, very quickly in terms of the number of cancer cases we were actually doing, in terms of the diagnostics we were doing, and actually we're seeing some improvement along that pace. But obviously December has put things into a backward motion, if that makes sense. So broadly, I'd say we are roughly along the same line as most of our peers, but doing slightly better in some places, like some of the elective cancers, for example.
Okay. And is there anything we need to, you need from us? Is there anything we need to be doing?
I think the key for me is, as we bring forward our plans for recovery, is actually the support in that area. We know the impact it's had in terms of workforce. We know the impact it's had in terms of the capacity has come down. We are bringing forward lots of conversation on our IS contracts. So again, when we bring that forward, it's a support in those plans will be absolutely key to moving recovery forward.
Okay.
There's clearly a significant clinical conversation to be had around patient prioritisation, which will need to be considered at the various clinical forums and other forums, and involvement in primary care. That would be absolutely crucial as we move forward. So again, at this stage, I think we are really well placed in terms of our forward plan. We really understand where we are in terms of our services. I think the support will come when we bring the plan forward to actually look at what might be required to recover the position.
Okay.
Sorry.
That's okay. So I mean, I completely get that we need to be supportive of all providers anyway, given the current situation. But I think it's just, I want to know at what point we start to be more challenging, because actually it's okay to look at figures and just get to a point where I think, well, it's COVID, situation's bad. I think at some point there needs to be a little bit more pressure applied. Pressure is maybe not the right word, but pressure stroke support, whatever is the middle, to make sure we are.
So I think in answer to that, I think the meeting I've just come from is suggesting that we are not likely to see sort of any hard targets around some of the things in the planning guidelines, for example, elective. But what we are going to be seeing is, as we did in phase 3, is essentially a comparison to our peers, which is the point you were making, Hassan, is how are we doing in comparison. So essentially there'll be essentially a league table that has region will hold us to account. And I think in some respects, that will sort of govern our actions. But there is also another conversation, I think, around our own aspiration in terms of, for example, 52 weeks. The backstop is likely to be anything from 78 to 104 weeks nationally. But actually, we should be, I think, challenging ourselves to try and get back to 52 weeks as quickly as we can. So again, once we set that aspiration, absolutely, there should be some challenge around the plans we put forward to actually try and recover the position to our aspirations. I hope that makes sense.
Yeah. Okay. Thanks, Ed.
Yeah, I think. Thanks, Paul. I think you was making the point I was going to ask you, but to what extent, to Hassan's point, should we build in some ambitions to the recovery, in the sense we've been given a national plan which tells us percentages to hit by month, etc. And the plan I've seen from ESNEFT is the strongest in the region, so that's very good. But to what extent should we be pushing local providers to stretch as far as possible?
So I think the answer to that question, Ed, is in several ways, really. The first thing is we are being told nationally that money isn't an issue, although I think that's yet to be confirmed into our plans. So we have been told, I think, to move as quickly, as hard as we can, I think, in terms of recovery. So I think in that sense, that conversation is well open to our own internal aspirations. I think in reflection, when you look at what we did with cancer, we've come to really high aspiration to actually recover the position relatively well, although there are clearly some concerns still around the impact COVID around cancer. We certainly had a discussion, as you know, at the Elective Restoration Board, that we should try and go faster than the national aspiration around the currently 104 weeks backstop, which is being discussed, back down to 52 weeks as soon as we can. So I think the door is open for us to aspire to as quick as recovery as we can. Clearly, a number of factors will slow things down. Workforce consideration will be an absolute key issue. The funding, to some degree, will be a key issue. Although we are being told that if we exceed our ambition, or the set ambition nationally, money will flow against that. So again, that shouldn't be an issue. And essentially, I think the answer to the question is we should absolutely be challenging ourselves across all of the measures, 18 weeks, RTT, cancer, to try and recover as much as possible. And I think the system has that aspiration, given the conversation we've just had.
Okay, thank you, Paul. Anyone else? Okay, in which case, thank you for the report. We acknowledge the recommendation. Thanks, Paul. Just before we move on to the next item, I should have said right at the start, if possible, every 30 minutes or so, I don't mind if people just turn their camera off for 5 minutes and just stand up while the meeting goes on. So try not to just sit there in your chair for 2 hours or so. So we're going for an hour and a half. I'll assume if your camera's off, you're standing up. You can by all means keep it on if you stand up, but just please remember to stand up and move about a little bit while the meeting's going on. And also every 20 minutes or so, stare at something outside the window for 20 seconds. I'll try and remember to remind everyone at the start of every meeting. So COVID, it's the vaccination report, Ed.
Thank you, Chair. So I'll invite Pam Green to add her comments as the local general of this programme. But just firstly, a big thank you to everyone involved. It's a huge team effort, not just the teams, but the partners such as the councils and also obviously the volunteers. We've had huge numbers of people, members of the public in North East Essex, come forward to support the vaccination programme. We're just very grateful to them and to everyone's efforts. In terms of our performance, we're performing very well against any metric you really want to look at. We've done the vast majority of our first 9 cohorts have received a first dose, and Tendring District Council area was the first area in the country to have over 50% of their adults with the first dose at the end of February. So some excellent progress. That progress has an impact, a positive impact. So as of today, there are fewer than 15 COVID positive inpatients at Colchester Hospital. And in mid-January, people remember I think we were close to 300. So that gives you a sense of the change. That's not all down to the vaccination programme, but I think there's a large part of that impact is down to the collective efforts. So it's in everyone's interest to move quickly, and we've absolutely done so. Whilst we've focused on the many, we've also focused on the few. And I think that's one of the aspects I'm most proud of the programme, is that we've thought a lot about inequalities and supporting all of our people, all of our communities. We've done that in different ways. We've held adapted clinics for certain communities. The Bangladeshi community, for example, in Colchester, we saw after 2 sessions at the stadium a huge uptick in the vaccination rate there. And the health outreach team from EPUT have done a superb job, and I've just seen the data that 98% of our homeless and rough estimated homeless and rough sleeper cohort has now received a first dose, which is an extremely high percentage looking across the board nationally. So we move into April, where due to supply issues nationally, we'll be focusing on second doses, and we've got guaranteed supply for those second doses, and we're starting with our over 80 cohort again, and in our care homes. So a lot of work to get through in April, and then we are expecting in May that the first doses will ramp up again, and we'll be hopefully by then moving into cohort 10, which is age 40 to 49. And then we're also looking into the future, and there's talk of a revaccination programme from the autumn, and maybe that will be combined with flu vaccination too. So we see this as sort of as painting the fourth bridge, that it's never going to be quite done, that there will be a rolling programme around vaccination for a long time. So the collaboration that we've got and the strong relationships that we've got around this is vitally important, so that we continue the effort over the coming months, if not years. So that would be my overview. But as I say, Pam's bossed this locally and done an exceptional job as ever. So Pam, do you want to give your perspective too?
Thank you, and I want to pay credit to GPPC, particularly Joe and Matt, who have supported the workforce recruitment and supported all of general practice to be able to provide this level of service that we have to our most deprived population. And also we've released a number of CCG staff that have done an incredible job, transferred from other roles into, the Laura Cook's just coming, whoever that was, just in the chat. transferred from other roles where they haven't had an operational leadership role before, transferred their skills and adapted brilliantly. So particularly Laura Cook, who was previously in IT, has shown exceptional leadership at hub level. Donna Harris, various other people. So we couldn't have done any of this without them and the leadership that we have seen at in primary care. Within North East Essex, we set up 3 hubs, and it is referenced within the paper. It's been the reason why we've had to release so much CCG staff, but it's also been a reason why we've been able to manage waste and really sweat the assets that we've got so significantly around particularly the Pfizer delivery of vaccine. We did have the help from the Army at one point when we were struck by significant COVID levels in our primary care workforce, and they were a great help to us and prepared to work evenings, and we were able to run evening clinics. Again, as Ed has already referenced, none of this could have been done without the support of our voluntary sector. The huge amount of volunteers in each of our hubs, in our practices, and also supporting the practices to do the bespoke clinics. I've referenced in the paper, particularly the Gurkha community that have such a strong relationship with their GP practice. It was, self-organised and a brilliant result for the local population. So I'm hoping, like in every good wedding speech, I haven't missed anybody, but we really have managed to deliver a huge amount. It is Groundhog Day. We're off again with care homes. Lisa and I'm sure. Well, I've certainly been out over the last few days. I'm sure she will be over Easter as well. And it's humbling and it's a privilege to be able to be part of the programme. But there's obviously turbulence around vaccine supply that we have to work around. But yeah, great success, and thanks to everybody that supported it. And as I say, particularly the primary care leadership that we've seen step up over the programme.
Thank you, Pam. Thank you, Ed. As you say, it's been a fantastic, amazing experience for the whole community, I'd say, to get involved. And so from everyone who's been part of the hubs, to the volunteers, to the random people coming outside of their houses and giving teas and coffees to the volunteers, I think everyone's played a part. So it's just been amazing to see. Frida, have you got a comment?
Oh yeah, I just wanted to say, send my thanks as well to everyone that supported the vaccine programme in tendering. I'm so proud of everyone there. Really a massive effort, and thank you to Laura and Joe and Matt and Pam in particular. I just hope we can maintain the momentum because people are getting a bit vaccine tired at the moment, so we're getting a little bit of workforce issues, but I'm hoping that we can just push on and carry on with the programme as it seems the hub model seems to work really well. So thank you all.
Thanks, Frida. As you say, I think we're getting to a point now, are we, where people are starting to get tired, and so I think it's just making sure that we're able to rotate people around in the right way to try and keep it going, and I think that'll happen. But it's also one of the reasons why we're so successful in terms of being able to get so many people vaccinated, that everyone's been giving over 100%, and I think we need to be mindful that we don't push people too hard as well. So as in Easter's coming up, people need their breaks, so we need to make sure we feature in for that. But it has been fantastic. Right, so audit committee report, Jerry.
Thank you, Hassan. Just to note that it's a committee in common. It seems to be working really, really well now, an integrated committee with the Suffolk CCGs. And we've also got integrated, or the same external and internal auditor, which helps. So our future plans are all aligned together just before we get separated. So happy to take any questions.
As I say, Jerry, you always get there in the end, before the end.
Yeah.
Have we got any questions about the audit committee report? Sorry. No. All right. Perfect. Well, thank you, Jerry, for what you're doing, and it's good to hear that it's all starting to come together as well. So that's fantastic. Right. Quality committee report. Lisa.
Thank you, Hassan. So I'll just pull out a few key items that were presented and discussed at Quality Committee. I think the first one is that we normally we are reporting concerns around staffing at the community hospitals in North East Essex, but there has been some improvement in staffing recently following. We've seen a return to the community hospitals of agency nurses, we think, who possibly went to work in the acute sector during the height of the pandemic. We've seen ESNEFT being able to volunteer more mutual aid, and we've seen some improvement on overseas nurse recruitment. So that's a really good position. I also wanted just to point out we did a quality assurance visit into maternity services at ESNEFT. Both myself, our regional chief midwife, our director of quality from NHSEI, who is also a midwife, and my clinical lead midwife with a consultant obstetrician from Norfolk and Norwich. And we made 7 recommendations to the trust. We visited both Colchester and Ipswich sites. There were some areas of really good practice we noted, but there were some areas of improvement that we've asked the trust to address. So we will monitor that through our next quality visit and through the local maternity board. From an IPC perspective, we've seen a real decrease in outbreaks, as would be expected, both in the acute sector and in the care home sector. I think we're now, at the moment, overseeing 9 outbreaks in the care home sector, which you may remember we were quite frequently overseeing around 37, 38 just in the care home sector in North East Essex. The other thing just to point out is that we were having virtual initial health assessments for looked after children with a requirement for physical assessment as soon as possible, but an Essex-wide audit that's taken place has demonstrated that the face-to-face assessments hadn't taken place. So we are just going through a process to identify all those children that haven't had a face-to-face assessment to make sure that the community paediatric service pick those up and do the face-to-face assessment. And just the other thing to point out is that the board will remember that CHC assessments were paused between March 2020 and the end of August, and then from the 1st of September we were asked to restart CHC assessments and to make sure that all our deferred assessments during that March to August period were completed by the end of March. And so in North East Essex that was 152 deferred assessments that the CHC team have had to make sure were processed, and I'm pleased to say that they've managed to do all of those. They actually managed to do them by the end of February. So thank you. I'm happy to take any questions.
Thanks, Lisa. But before I bring questions in, I don't know whether you wanted to, I know you put a comment in the box, Pam, but Pam D, sorry, did you want to add anything?
No, thank you, Hassan.
Thank you. Okay. Max.
Thank you, Chair. Can I just ask, regarding the vaccination of staff, we seem to have a lower percentage for BAME staff. Is that right? Is that right? And if so, what can we do about that? Because obviously they're clearly at higher risk than non-BAME staff.
Do you want to come back on that, Lisa? Do you want to?
I think that was on the was that on the previous paper, Max?
Oh dear.
That's okay.
Am I behind? Sorry.
That's all right.
Okay,
I
sorry
think that was on Ed's paper.
Well, this is in the quality.
Oh, is it? Oh, I'm sorry.
Quality committee overview report.
Oh, I'm sorry.
It's there in.
So
can you bring a page up, Max? So
it's quality COVID. It's number 3.2.3.
There you go.
Sure. So, I mean, I think reflecting back to what Ed was saying in the vaccination programme update, we're doing a lot of work around all people that aren't coming forward for vaccinations. So people from BAME and also people with vaccine hesitancy. We've seen in the care home sector, particularly young people who are concerned about fertility issues. So we've done a number of community engagement sessions. We have a whole range of bespoke vaccination services. I think Ed was referring to the Bangladeshi vaccination clinic that was held at Colchester Football Stadium, and but we continue to need to make sure that we're engaging with all of the groups that aren't coming forward for vaccination. I don't know.
I think I was talking mainly about staff though, Lisa, because this is about staff, isn't it?
I wonder if Pam can answer. Pam,
sorry.
You're on mute, Pam.
Yeah, so there's been some concentrated work with occupational health departments around their staff, and a conscious discussion with those groups as to why they didn't want to take up the vaccine. There is, because the workforce is quite significantly female and younger, the infertility thing that Lisa has mentioned has been one of the strongest themes that's come out, whether you're talking about the healthcare sector or whether you're talking about care home staff, because of the profile of the age. But as I say, as a responsible employer, I mean, there has been some discussions around staff not being able to work in care homes if they haven't been vaccinated. So it's now down really to an occupational health intervention, and those conversations are happening with line managers directly with those that have not taken up the vaccine. In the same way as we have to take up hepatitis B vaccine to be able to be on the wards, it's now becoming an occupational health requirement. So so that's where the encouragement is coming from now.
So just to be clear, I thought, so if we're talking about 3.2.3, I thought that was about East. So it's East BAME, or is I misunderstood? Is that about all staff?
Oh, right. Oh, you're right.
Can I suggest, Matt, that I get a most up-to-date position from East on how they are liaising with their BAME groups, and I'll circulate them.
Thanks for that. I mean, Ed's desperate to get in. I don't know whether he's got the answer for this, have you, Ed?
Well, I know that East have now given the first dose to 95% of their staff. So I think hopefully that issue's been worked through. But the really good point, which is what Pam made, is we've looked into the ethnicity issue a lot, and we're finding actually the bigger issue is gender, and it is fertility concerns. Wow. So I think that's increasingly the focus of the vaccination programme in the system. Is actually on gender.
Okay, thanks, Ed. I mean, also East is a massive organisation, so it would be interesting to know geographically whether you can whether that's a particular area that's struggling with their. But as you say, if they've got 95% of staff, then I'm assuming those figures must be really out of date now.
Yeah, they've done really well just recently.
Yeah. Okay. Was there something else, Ed? Or did I?
I was just going to ask Lisa. I know there's lots of things that no doubt keep you awake quality-wise, but what looking at North East Essex, what's the big issue on your mind from a quality perspective?
So it would have been care homes and outbreaks, but obviously we are really through the vaccination programme that has really improved. I am concerned about the maternity services at Essex relating to Colchester. I think I'm assured around safety, but I am concerned that the rollout of the continuity of carer programme is paused, and we know that by delivering continuity of carer through midwifery teams, particularly in areas of deprivation, it can lead to some really improved outcomes for women and children. So I think that's for me, that's one of the biggest focuses that I would like to see improve.
Thanks, Ed, for the question. That's useful to know, Lisa. Interesting to know your updates on that now then for the next board. Any other questions? Sorry. Perfect. In which case, I'll move us on to the primary care commissioning report. Pam, is that you?
Yeah, it is. Yeah. So this is our usual report that we do from the renamed GPCC to the PCCC, because that was on the advice of NHS England. So if people are looking for that previous committee, it's now known as the Primary Care Commissioning Committee. I'll take the paper as read. We've undertaken usual works around quality management and supporting vaccine rollout and the pharmacy support. Been a little bit more difficult to do the additional roles during COVID because of the focus on the vaccine programme. But I'm happy to take any questions on the paper and the work of that committee.
Thanks, Pam. Have we got any questions? Can I ask about the list closures?
Yeah.
Because as I understand it, they're limited, aren't they? So you can only do it for a certain number of months. So it'd be useful to know if they're the same four that we're aware of, and when they come up for opening, and what we're doing to support those practices to open their lists again.
Yeah, so these four tend to yo-yo in and out of. It's the same group usually that open and close, and some have got historic arrangements that are single-handed, but we support them with NHS England around recruitment, around working within their PCN to enable lists to open. But it is the usual ones that you'll be aware of, Hassan.
Okay, all right. Because I couldn't understand what you meant by contract variation agreements. So you don't, do you have to vary the contract for?
No, so there was some historic arrangements that NHS England had put in. So it was, but we make sure that there's no further payments, obviously associated with register. So you used to have your list open to be able to claim elements of additional funding. That was the restriction.
Okay, things like PMS to GMS, does that still get?
Yeah, so that was all. I mean, we've had to take a more liberal approach this year because of COVID, but that was exactly the sorts of things that you used to we used to have to watch.
Okay. Does anyone else have any questions, comments? Okay. Well, thanks, Pam, for the update.
Thank you.
Could we possibly get next meeting though, just an idea of timelines when those lists will open, just
yeah,
of curiosity more than anything else for the public.
Yeah, absolutely.
And you're doing the next item as well, the APC reports.
Yeah, so there's no questions on the performance report from primary care. We'll move on to the APC. So APC reflects a joint committee across the ICS, which is delegated to from this board to make decisions around prescribing. The majority of the work that, and Prashant is our clinical representative on here for North East Essex, but the majority of its work recently has been around the PGGs, the SOPs, the standard operating procedures around the vaccination preparations for Pfizer and for AstraZeneca. So they were signed off through that committee so that we could embed the national protocols to enable higher throughput through our practices and our hubs. And there's a range of other medications that they've taken a view on recently around guidance, etc. But quite happy to take any questions on those items. You'll see that antimicrobial stewardship remains within our focus. and one of the impacts of remote working has been a high.
You've gone on to mute, Pam, but that's okay. We'll move on to questions, I think.
Sorry,
Right.
don't know how that happened.
It must be a computer can read my mind. So, any questions or comments about the APC report? Prashant, did you want to add anything as our rep? Are you there, Prashant? Okay, maybe he's having his 5-minute stand up. Hold on. Right.
Yeah, tell me. Sorry, what's going on?
We've
Right,
just done the
welcome to the meeting.
APC. We've just done the APC report, Prashant. So I was just saying that we've covered predominantly the standard operating procedures for the vaccination programme, etc. There are some other medications that we've covered, but we were just taking questions. But did you want to add anything? He is in the vaccination hub.
Yeah, no, I think you've covered most of the stuff, Pam. I was listening, but then are you there? Prashant came up, and then I thought I'll just.
Oh, I didn't realize you're actually jabbing whilst the meeting's going on. You, that's fine.
No, I'm not jabbing. I've just come here now.
Right. Okay. All right. Perfect. Well, no, thank you, Prashant. So if there's no other questions, comments, I'm just going to pause for a second. We'll move on. So let's move on to. Thank you, Pam.
It's okay.
And thank you, Prashant, for attending. Crack.
Yep, thank you, Chair. So paper in your pack just gives you a summary of the decisions that have been through the committee since we last met. We took the same paper to the Finance and Performance Committee last week, so it was given a level of scrutiny there, but it's probably best if I just open it up for any questions.
Thank you. So have we got questions? No? Sure. Okay, and so we've already earlier on agreed to extend crack till September. So, okay. I could ask Jerry, couldn't I, in Martin's absence? Jerry, did you want to add anything?
No, that's fine. Okay. Thank you.
All right. I think, so thank you for the report, Jane. And thank you for your leadership with crack. Actually, I think it does run quite slick. On the rare occasion I get to go and chair, it's quite helpful having you there. So grateful. So Alliance Committee overview. Pam, so that's you again.
So thanks to my chairman and chairwoman, deputy chairwoman on the Alliance Committee, the voyage of discovery in establishing another committee continues. I think we're starting to get some real progress now. We've undertaken a significant amount of work in the Alliance around integration recently, and referred items onto and received items from the Alliance board around very timely discussions around how we integrate with health and social care for the future. We're starting to get the governance re-established within the wider Alliance, so the feeding up of reports will be in a much more ordered style for the Alliance. But we've seen many of the items that have come here today around SEND, etc., come through the Alliance and allowed our clinical representation to have input into the consultation on those items. So I think it's starting to work. There's a lot of wider determinants of health comes to that committee because it has a broader church than health alone. And I see this as the blueprint for the future for decision making and leadership. So thank you for everybody that bore with us while we were finding our feet. But I think you'll see that the report demonstrates that the governance is aligning and we're starting to have a broad range of conversations. So very happy to take any comments.
Thank you, Pam. Have we got any questions? No, okay. Thank you, Pam. Thank you, Mark and Frida, for your chair and deputy chair roles. Oh, Frida.
Can I just ask, how are the Alliance committees going in the other areas? I don't seem to know. Just out of interest, how are they developing?
Have you got an Alliance committee? like we have in the other areas? You mean Suffolk, do you, Frida?
So North East Essex is further advanced than the other two in terms of having an alliance committee. I think it's a great model that we've got here, and perfectly in line with the white paper. The other two, the Suffolk alliances, are also they're built around strong relationships and have got great conversations and work going, but the governance isn't as formalised as it is in North East Essex. So effectively, they've committed to follow the path here to do something very similar.
And the timeline for that, Ed, is in terms of them catching up with us and having the three committees pretty much on par with each other.
Yeah, catch up with us, Frida.
In the coming months, I would have thought. Next 2 or 3 months.
Great, thank you.
We'll always be ahead, right?
It's just good to push that point. That's all, Hassan.
Thank you, Frida. So as I said, thank you, Mark, for your chairing the Alliance Committee. So if there's no questions, let's move on to staff survey report. Amanda, are you going to take us through this?
Oh.
You're on mute.
Hopefully not now.
No,
Good.
that's perfect.
Thank you, Chair. So this is the 6th year the CCG has participated in the National Staff Survey. As colleagues will have seen, we had a pleasing response rate of 74%. So since last year, we've seen a number of improvements, and I've picked out a few from the report. So a few are support from line manager is very pleasing. We have a high degree of job satisfaction in terms of staff being able to use their skills. And indeed, staff feel they're able to make a difference to our patients and service users. 68% of our staff would recommend our CCG as a place to work. We also received very good feedback in terms of the positive steps and action we've taken predominantly in the last year with regards to the health and wellbeing agenda. And I think, you know, there's been a lot of work from the Health and Wellbeing Group in particular, who continue to meet monthly and also send out weekly messages to our workforce, which is tremendous. So whilst we have a good survey, we're never complacent, and our organisational development group are now going to be addressing some of the key areas which are cited in the report. And I've picked out again a few. One around communication and making more awareness on who our senior managers are. There's also something around maximising opportunities for flexible working, and we want to be doing a little bit more work with our staff around job satisfaction. In terms of page 6, I wanted to pull out a few reflections from our directorates, and some of the key highlights are as follows. Our staff feel trusted and valued to do their jobs, which I think is a very good indicator. And also staff feel supportive from their immediate line managers. And generally speaking, our staff feel a general sense of satisfaction. And the last point that I wanted to flag was that staff also feel that the care of patients and service users is a top priority for our CCG. So I think that's very good news indeed. So in terms of our next steps, we have started to socialise the staff survey with individual teams and directorates, and we're now going to be working through what more we need to be doing with our organisational development group across Suffolk and North East Essex. That will culminate in an action plan which we will take through to REMCOM in due course, which will eventually find its way to governing body. So they are the key highlights, Chair, from this year's staff survey, but very happy to take any questions. Thank you.
Thanks, Amanda. So before I bring everyone else in, so you know, when we talk national average, is that national average taken off CCGs or the NHS?
CCG. It's the CCGs.
Okay, I mean, so thanks for pointing out the highlights. There's some concerns, some significant concerns in the report as well, isn't there? And it's what's even more upsetting is that when you compare it to the national average, they're equally as concerning. So I think it's a reflection of well, I'm not sure what it's a reflection of, but it needs some looking into, I think.
Absolutely, and that's what we're committed to be doing, Chair, with our colleagues.
So let's see who's up first. Frida.
Yeah, I just was going to bring up, like, you highlight the good aspects of the report, but you don't highlight, Amanda, the negative comments, which, you know, are alarming, particularly on the backdrop of what we're not allowed to discuss. I just want to say that, you know, we really do need, as an organisation, to reflect upon this survey and reflect on the negative part, and not be open to that. You know, it's not good enough to not speak about the negative feedback that we got from this survey at board, because we do need to have that conversation, and particularly on the basis of what we earlier discussed. You know, it's not good enough with an organisation at leadership level allowing for behaviours that are unacceptable, and this is highlighted in the survey.
Okay. I'll take a couple of questions if that's okay, Amanda. We'll come back to you. Max?
Yeah, thanks, Chair. Yeah, well, that's basically similar, to be honest. I mean, yeah, there does seem to be. I was going to ask about the averages, because we do seem to be below average on quite a few things. You know, staff looking forward to work, staffing levels being sufficient, staff feeling able to provide the care they aspire to. You know, just to pick a few. So I think they need to be addressed. Yeah, thank you.
Ed.
Yeah, I think one of the issues that I think will become even bigger, if I'm honest, is the fact that North East Essex CCG has gone from an in-house model largely, with everyone under the same roof, to a more dispersed leadership model across 3 CCGs, and I think that accounts for some of the feedback about visibility of senior staff and that sort of issue. And we're going to be moving to probably an even bigger commissioning organisation over a bigger geography. So the culture change from having everything in-house and local to having something that is dispersed over a big geography is going to be a really big issue for the staff, I would suggest. And I think that has presented issues over the last 18 months with the arrangement with Suffolk, and I think it will continue to present issues. I think there's something we need to do about how we think through that changing context and how we support staff in that culture change, or that change of circumstance, for so.
Okay, thanks, Ed. That's quite a few people. So I don't know whether you wanted to come back on any of those, Amanda. I guess the point is that people are seeing the negatives, aren't they? And so it's around making sure there's some perhaps urgency or about how we're going to recover some of this. That's what they want to see, don't they?
Absolutely. And just to come back on a couple of points that were made, Chair. So we have started, as I mentioned earlier, having the conversations within our teams and at directorates to understand the survey at team level. And we are wanting to be working through our organisational development groups on what more we can and should be doing. So we have that complete staff engagement and buy-in. And that's something that we are committed to and have started.
Okay. Thanks, Amanda. Pam D.
Thank you, Hassan. I just wanted to pick up on Ed's point, if I may. I think he's absolutely right. If people are feeling distant from their leaders, they're going to feel even more distant given the forthcoming arrangement. So I think it's absolutely vital that we invest in strong, local, respected leadership so that people feel that some of those concerns expressed in the survey have been addressed. I think my second point is around Amanda's point in relation to the use of the organisational development groups. And from my own experience elsewhere, I think the intervention of an independent critical friend in the context of a listening voice that doesn't have an agenda is a useful part of that listening process that I'd like to encourage us to give some thought to.
Thank you, Pam. That's really helpful.
Thanks, Pam. Max. Was that a legacy hand, Max?
Oh, no, it's not. No, it's not. Okay. So just, yeah, I mean, I think we need to, and I'm not quite sure how we compare to, or maybe I missed it, but not quite sure how we compare to previous years in North East Essex CCG, because, you know, one of the things that I've noticed noted previously about the CCG is their focus on mental well-being with their staff, and in fact it was what kind of inspired me to think about how can we not do this with primary care, and I raised that at a board maybe 2 years ago, and because it was really quite noticeable how much we focused on the well-being of our staff, and yeah, I think there is a problem. I think there's two problems. One is the problem that that we've got with COVID, in that you haven't got people in the office environment, and it's quite difficult to manage the situation or to make people feel valued. If you're not actually working, face to face with people, and I think that is a problem. So that must be a problem, generally across all CCGs at the moment. I can't remember the other point now, but I think it's and the other problem is, as Ed has highlighted, is the fact that people, the senior management structure is such that they're not local to the people working within the CCG, and that's just the way it is. That's just the way we set things up, when we decided to effectively merge senior management structure. So I think there are a couple of problems there, which you can and possibly things that we couldn't do anything about the COVID pandemic. The COVID pandemic is what's happened, but when we can't, the merging the senior management was something probably we couldn't do anything about. But it just means we've got to redouble our efforts to actually make things good for our staff, because we know those things. So we should be doing something about it to make sure that our staff still feel valued, and want it to be a place that they want to work in. And I just sorry, I know I'm going on, but just the sort of saving grace recently has probably been the vaccination program. Suddenly some of these staff are seeing each other and talking to each other and feeling more positive, about what they're doing, possibly, and I think that's been a bit of a saving grace. So we should try and build on that, that superb response that we've had locally to actually improve things for our staff. Sorry, that was a bit long-winded. Sorry.
No worries.
No,
Thanks,
thank
Max. Pam G.
As has been mentioned before, we're doing deep dives and a more thorough dive per directorate into the themes that are coming out and aggregating those together, because we've obviously got staff that are on different payrolls but under different directors, and with potential changes, it makes the matrix working and the FEMIC evaluation quite difficult to do. So we've all committed to evaluating our teams with the HR expertise within Amanda's team, and I think what we need to do is bring that back to further meetings to give you the assurance that we understand what's driving some of the deterioration, and how we, as Amanda's already referenced, how we make that development plan clear and understandable as to how we support staff. I'm really particularly interested in ensuring that people are in the best place possible for any further changes that the white paper might bring about. And whilst we don't know exactly what that is, we have a duty as a board to make sure that our staff are in the best place possible for that. So I think it's something that I'm quite happy to bring back, along with the other directors. I'm sure would bring that back to here as well.
Okay, thanks, Pam. I wonder if perhaps we could get an update next board, Amanda, in terms of what's happened in the preceding 8 weeks, and what plans we've put in place to try and recover some of this.
Absolutely.
And maybe that involves looking at, as you said, the OD process and whether or not we do interim reviews, one-to-ones with select groups or whatever, the sort of deep dive thing that Pam's talking about in terms of just trying to uncover some of the issues. I do appreciate that on the backdrop of the national average, the national average isn't pretty great either. So I think there's something we're probably nationally doing bad as CCGs, but it's hard to know whether that's, as people have said, COVID related or just generally the way we're working, or if there's even some uncertainty creeping in as a result of things like the white paper. But as I understand it, this was done before the proposed changes, wasn't it? Fine.
October, November last year.
Paul, do you want to make a last comment?
Yeah, I just wanted to give a bit of a reassurance that from a director's point of view, we are doing exactly what Pam is describing. So I've already had a meeting with HR colleagues and 2 meetings with my teams, a workshop with my team, with another workshop for next week, to really try to get underneath what is driving some of that. My underlying sort of view, there is a clear sense of isolation coming through. So in a sense, they are delivering over and above because they want to support. There is something about not being an expectation, but also reminding people that downtime is really important. There is something about teams meeting that normally would meet on a regular basis, but don't get a chance to because everything has to be planned and processed through Microsoft Teams and all that sort of thing. So it's really important to get underneath, I think, some of that information to bring you back to a ground up plan and essentially just to reassure that's what we are doing as teams at the moment.
Okay, thank you, Paul. Let's hope that that's the right thing and it gets us to the right place. So Pam, you got your hand up again. Pam G. So.
Yeah, it's a very final sort of comment that Teams or Zoom is ubiquitous across industries now. It's not that we can say the way of working in the NHS is different to other organisations. So we can take learning if indeed it comes down to that isolation. It's some really good practice that the private sector has employed to support its staff, because they haven't been dealing with a pandemic face to face. I think that's the double jeopardy of the NHS. We've had to completely change our work model as well as respond to COVID. Other industries have had the fortunate position to just have to respond to changing their business model. So I think there is definitely some learning out there that we can translate into supporting our workforce.
Okay, thank you, Pam. So look forward to getting a bit of an update next board, if that's okay, Amanda. Have you frozen or?
No, I'm here.
Oh, okay.
I'm here, hopefully.
Just sitting deadly still there. Right. So you're right to give us an update next board.
Very happy.
Perfect.
No, very helpful, very useful discussion. Thank you, everybody.
Okay. And then the next item is yours as well, actually, board assurance framework.
Absolutely, thank you, Chair. So I'm taking the paper as read, but here we have the March Board Assurance Framework, which highlights our current strategic risks, of which we have 11. All of those have been updated since we last saw as a collective, and we actually, as a directorate team, reviewed the latest framework yesterday, and we've identified that there will be a new risk added, not to the board assurance framework, but to a directorate risk register, notably around the white paper. And as we understand and learn more about the white paper and the implications, it's very likely it will come onto the board assurance framework in coming months. But I leave it there, Chair, but very happy to take any questions.
Thank you, Amanda. Any questions? No. Okay, perfect. Well, thanks again, Amanda, for the 2 items.
Thank you.
And so I think I must confess, as I said earlier on, Councillor Brown's not joined us for the health and wellbeing report. I'm not sure if actually she was meant to come today or attend not, but I didn't get time to do a report myself. I don't know whether there's anything you could add, Mark, if you've got notes somewhere that you can.
No, to be honest, I can't remember. So
I'm glad you said that.
My appointed role, I would, but I'm afraid.
No, well, I'm afraid when I discovered Councillor Brown wasn't going, I tried to look through my emails for the last agenda and I couldn't find it. So I'm afraid I've gone blank. So
there's one thing, sorry, Hassan, I can assure you of. We had a presentation either to our board or to the Alliance Committee about experiences of families with carers, and I think it was something that I found quite disturbing. So I've taken it from here, from our CCG to the Health and Wellbeing Board. So I do ensure that overlap happens, and that will be part of an extra meeting that we're having later this month.
Okay, perfect. Thank you. I should get in touch with Councillor Brown if, in fact, Councillor Brown is not coming to board anymore because she's stepping down, I believe. I'd just like to minute my thanks for her contribution to board. I'm not sure who's replacing her, but I guess we find out post-elections, don't we? Perfect. In which case, I've not been advised of any other business. So the next meeting will be on the, oh no, wait, it'll be on the 8th of June. So if I could just make a note to our comms buddies who are listening in, I've changed the date for the next board meeting because I realised it was in half term. So we've swapped it over with the Alliance Committee, and as I understand it, I hope that's been run past you, Mark, as chair of the Alliance Committee, because we've swapped them around. Perfect. Excellent. So the next meeting will be on the 8th of June. And I wish you all a good evening.